We'll be talking today about, let's see if I can do this, a little bit about serious illness conversations, and then how do those translate into the work that we're doing with TPOPP across the states of Kansas and Missouri. So acknowledgments, if you see any of those little markers, that signifies Ariadne Labs and the Serious Illness Conversation Project out of Harvard, which is really pretty integral to what we're trying to accomplish in improving conversations that we have with folks. Hi, nice to meet you. So I went to this training about a month ago and kind of learned this. Part of what we're wanting to do is improve the conversations that we have with serious illness patients, seriously ill patients and their families, and then translate that into infrastructure across the community. So our objectives will be to understand functional trajectories of patients with advanced illness in the few to several months prior to death, and then incorporate serious illness care planning into provider workflows so that we're hopefully doing more, better, and earlier conversations about goals of care with our seriously ill patients. Next, we'll describe TPOPP. This is the community infrastructure to honor the results of excellent serious illness care planning, and then look at the evolution of TPOPP as a POLST paradigm. So we'll talk about what is POLST and how does TPOPP relate to that. We'll look at data on effectiveness of POLST, and then tell you about how to join the bi-state initiative if the community here decides that you'd like to do that. So first we'll start off with a little story that hopefully everybody, or probably everybody, will relate to. Roy, 71-year-old with severe dementia, severe COPD and mild dementia, and skilled after a recent hospital stay for pneumonia. Now with increased shortness of breath and mental status changes, EMS gets called, he's not responding, and he's hypoxic. Recent conversations with his staff: I don't want to be kept alive by machines, I want to die in peace. So EMS gets called, applies oxygen, transports Roy to the emergency department. Don't know where those conversations with staff were documented or who all knows it, whether it's hearsay or in the record or what. In the emergency room, he's unresponsive. He's hypoxic. They give him oxygen. Chest x-ray shows large lung volumes without consolidation. He has a marked respiratory acidosis. He's intubated and transferred to the intensive care unit. Now Roy's daughter's contacted. She's not with him at the time. Made plans to come to the hospital. Over the next few days, he becomes more responsive, but he's still confused, agitated. The daughter's distressed that her father's wishes weren't followed, and they make a decision to make a DNAR and to extubate to comfort measures. So after the tube's out, he calms. They get him back to the skilled unit. After a few days at the skilled unit, he passes away. Is this a story you guys have around here? Yeah. So the hallmarks of the story are that somebody may have expressed wishes about what they would or wouldn't want if they had rapid change in condition, but it's not structured in a way that the information is known across care providers or known at the time when the patient's condition is changing. So they end up going into the hospital where we're excellent at the doing of things to pull somebody away from the jaws of death, which, hey, I'm glad for that. And, you know, for normal people, if I were to get sick, I'm not expecting it. I'm glad that our healthcare system is built that way. But if somebody's dealing with a serious illness and would want a different response from the medical system, we've got to have infrastructure in place so that that person's understanding of their illness and wishes around their illness are honored over time. So there's a gap between what patients want and oftentimes what they get. Patients with serious illness may have priorities besides living longer if we ask them. Symptom management and quality of life, a sense of control and completion, and strengthening of relationships. All data, pretty repeated, comes back over and over about what people say they want if they know they're in a situation where end of life may be coming soon. Most people want to be at home and prefer a comfort-focused care plan if they know they're at the end of life. often not the reality that comes to play. 86% of Medicare beneficiaries want to spend final days at home. 25 to 39% will end up passing away in an acute care hospital. 70% are hospitalized in the last 90 days. 29% receive intensive care at some point in the last 30 days of hospitalization. Many experience care transitions and very short hospice stays. So we're coming to learn that more people are ending up on hospice before they die, but many, many, many have a length of stay 72 hours or less. So what patients get often harms them and their families. Aggressive care for patients with advanced illness can be harmful. For patients, lower quality of life, greater physical and psychological distress. For caregivers, more major depression, lower satisfaction with care. So time for advanced care planning. We all know we need to talk with our patients about these things, but it's really hard. There's probably a confluence of several factors that pushes us away from that. Patients and families have got to be willing to talk about it. There's studies that show 60 to 70% of people will affirm that speaking with their family and their doctor about what their wishes are is important. Only 15 to 20% of those folks actually will do that, even though they know it's important. They're waiting for the provider to bring it up. They don't want to talk about it too early. They don't want to talk about it too late. It has to be just exactly the right time. So conversations are often too little, too late, not that great. Multiple studies show patients with serious medical illnesses don't discuss their end-of-life preferences or first discuss them very late into the illness trajectory and the last days to month of life. With advanced cancer, study that showed first conversation was a median of 33 days prior to the patient passing away. 55% of initial end-of-life conversations ended up in the hospital. And only 25% of those discussions were conducted with their oncologist. So when we think about somebody being in the hospital, they're at a time of more crisis, they're not feeling as well, they're likely to have more medications on board that can cloud their thinking to where they capacitate for life and death decisions. So when over half of the conversations we're having is in the setting of that, it puts us against the 8 ball from the very get-go. So I love this slide. It really helps us think about concepts of advanced care planning versus a terminology called serious illness care planning. So normal, healthy people, not dealing with a serious illness, not kind of on any sort of trajectory. When we think about what's good advanced care planning for that person, it's them thinking about what would my values be if I had a future state of a medical illness. What would be important to me then? It's a little bit of conjecture because we're trying to imagine something that doesn't exist. The important elements there are making sure that our loved ones know our values in general. If we're able to define things that would or would not be important to us, naming a surrogate decision maker, knowing somebody that you love and trust who could speak for you, and the idea of having an advanced care planning document advanced directive. When we get into the concept of serious illness, so this is anyone where it would not surprise the medical providers if that person were to die in the next year. Not that that person has a prognosis of a year or less, but that it would not surprise us if that person were to die. That's kind of the umbrella of might this be important to be thinking about and talking about. So thinking about prognosis, when they look at how long do those folks actually end up living, median survival is on the order of months to a year, sometimes longer depending. That question, the surprise question, is validated in end-stage renal patients and in cancer patients. We need to do more studies on congestive heart failure, other medical conditions, but it turns out the surprise question is more accurate in predicting who will actually pass away than our current hospice criteria for enrollment, the Medicare rules for hospice enrollment. So thinking about the seriously ill folks, they're now facing change in health condition where it's more immediate. What would they want to see happen and what is important to them if the bottom were to drop out. And that's a little bit different conversation than imagining the future. So when we talk about serious illness care planning and conversations, it's planning in the context of progression of serious illness, and the providers are identifying that person and their family need to be thinking about that as a possibility now. When there's crisis and decline in the midst of that, different conversations about goals of care and how people make decisions and set their priorities, if they're in the midst of that time, is likely different than if they thought they had 20 years left to live, as opposed to maybe I only have a year or less to live. And then looking at prognosis of weeks to months, revisiting those things and revisiting those conversations as illness changes over time. So goals of care discussions are really decision-making in the context of clinical progression and crisis. When you hit the forks in the road, we can do X, Y, or Z. Which one of these fits best with what your goals of care are right now? So reasons why this is hard, but I love the concept of the surprise question because it doesn't demand an answer about exactly how long somebody has. We know that estimating prognosis is really hard. We know that doctors tend to overestimate prognosis by a factor of 2 to 5 times. So if we're trying to get down to the nitty-gritty of numbers, we don't do a very good job of that. In the support study, this was a big study in the 1990s. You had to be pretty sick in order to get on the study, patients. Lots of interventions to see if they could improve end-of-life care, and it turned out the study failed. But there are some really good data that came out of the support study about kind of the state of end-of-life care management in the 1990s. One of the questions they asked the doctors who were taking care of these seriously ill patients in the study is, how likely is it, do you think this person will be alive in the next 6 months? And a high percentage of the time, the doctors would say, yeah, I think it's pretty likely that this person will be here in the next 6 months, and they are actually making that statement in the last 48 hours of that person's life.
Is that because we're optimistic? We believe a lot in our ability to help people? Just because a lot of these people, we've seen them with the same thing 3 times.
Yeah.
And every time they walked out of it and walked out.
Yeah.
So
yeah,
it'll probably happen again.
I think it may be a lot of everything you said, combination of factors. So thinking about functional trajectories, I think, is a big reason. This is my own supposition about why it happens, So I'll take you through this here and see what you guys think. So if we're able to identify the trajectories that people get on in the last months to a few years of their life, then that can help us to know. There are 3 main trajectories. One is the cancer trajectory. This is metastatic disease, where disease burden is growing, people are getting cachectic, the illness is not responsive to therapies, and it's a pretty straight line. That's about 30% of people end up dying on that trajectory. This one is the non-cancer illness trajectory, and this is 60% of people 60% of how people die. And so it's characterized by, and this is multi-comorbidities. Your heart doesn't work great, your lungs don't work great, your kidneys get the vancomycin, and then you fall down, break your head. So person's trekking along as good as they get, and then bam, the bottom drops out. I know. So
That's life.
I think this slide is the reason the doctors didn't know. Is because they were being asked the question within 48 hours. The patient was as good as they get, and trucking along at a functional baseline, and then bam, bottom drops out. They come in the hospital, we tune them up, they get better, but they don't quite get back where they were before. They establish a new functional baseline, they truck along at it for a while, and bam, bottom drops out again. And if you look at the global slope there, it's going down, but it's unpredictable when the bottom's going to drop out. It's unpredictable whether or not the patient's going to come back from it or not. So you named like all that. You've already done this entire slide, so person was as good as they get. Shocking to the family, even the doctors don't see it coming. They end up in the hospital, end up in the ICU if there have not been good discussions, you know, beforehand, and a plan that's already in place for how they want the medical system to respond. It's actually called the Lazarus Effect. Dad's gotten better 6 other times. He'll get better this time too. And you know that I always kind of point to the daughter who's saying, well, what went wrong? Because he was fine yesterday. And he's gotten through this other times, and so I don't believe what you're saying to me. And she's just telling you her experience of the trajectory. I draw that trajectory out when I meet someone and I'm like following their hospitalizations. I'll draw it out and then I'll show it to the patient and family. I'll be like, does this look like you? And they're like, yeah, that's totally me. This is in JAMA 2003, Patterns of Functional Decline in the Last Months of Life. And really great article. Thousands and thousands of Medicare beneficiaries where they matched up what were the patterns of decline that we see. So this is the frailty dementia trajectory where folks, they get to a low functioning state and then they may live for an unpredictably long period of time in a very frail state where they may or may not be capacitant. And then you start to see major organ systems shutting down and they work into that non-cancer up and down, you know, until they pass away. So the frailty one, you know, really looking at how come we don't see it in long-term care, that this slow progressive decline, it's easier to see in retrospect than it is right up front. Gradual weight loss, also a rehab culture and focus on the doing and putting back together. Fear of failure, weight loss, wounds mean poor care as opposed to skin failure, our largest organ in our body. Putting all those pieces together can be hard for somebody on a frailty trajectory.
You know, we contribute to that because our you know, medical system, like research, they'll go in and they'll pick one problem like urinary infection in the long-term care. And it turns out if you focus really hard on somebody's urinary tract, you can make it better. Right. And then they'll say, okay, well, let's do physical therapy. And it turns out if you do physical therapy really intensely for a while, you can make it better. And so you got all these little things that people did a study on. Focus on this, you can make all these things better. And when you stand back globally, you say, we didn't change the course of human events here.
Right, yeah. Yeah, you know, when I draw that graph out, or if somebody's telling me like, I just don't understand, she was just fine. And I'll say, well, think about your mom a year ago. Let's go back a year ago. Tell me about your mom a year ago compared to now. And that pulls them into that frame and they're like, oh, I don't even recognize her compared to a year ago. You know, to try to get our thinking about exactly what you're talking about, the little bits of here and there versus the global changes that we see over months, longer period of time. So if we really want to have a good plan, and if people want to end up on the comfort-directed plans that we hear over and over again that people want to be on, then thinking about this, talking about it when somebody's stable, in a stable place, not in acute crisis, and having a plan for what they would want to see happen when the bottom drops out is important. People get sick so fast that if we haven't done it ahead of time, it's already too late. And Roy's in the ICU intubated by the time anybody gets there to say, oops, this is not what Roy wanted. So conversations are really a key component of effectiveness here. And multiple studies showing that earlier conversations about patient goals and priorities are associated with enhanced goal concordant care, improved quality of life, reduced suffering, better patient and family coping. So there's better bereavement outcomes for family members when they know what their loved ones' wishes have been, higher patient satisfaction, and less non-beneficial care and costs. So we we is coming from the palliative care world, and we have I don't know how many beds there are now, like 700 beds, and I run about 30 patients on my palliative care service. At any given day, there's between 130 and 150 patients under our roof who would qualify as seriously ill, and should we have a conversation. So the idea of a checkbox for one expert who can just come in and have a goals of care conversation, it just doesn't work. You know, there are too many of these conversations that need to happen. And you know, the right way to have these conversations is with the providers who have known these patients for years and develop that relationship to say, we're getting to a place where it's really important to balance your wishes, your values, your preferences with what I know about your medical condition and your prognosis, so that we bring all of that information to the table. So this idea of having serious illness conversations is about breaking the box and saying, this is just plain good medical care for how we approach these folks and provide good patient-centered care. So you have some things that are in your kind of packet, and it is a little bit of an introduction to the concept of serious illness conversations. And so the folks who were in Salina a couple weeks ago, you have a much prettier version. But they're here for your reference. We're using these now, starting to build these serious illness conversation guides into our workflows, my workflows at KU, to guide us in having better conversations. So there's a whole other training program that we do, and this is what we were doing in Salina, where you learn about this and then you actually practice. And you were there, weren't you? Yeah. So actually practice having these conversations in small group sessions. So I wanted you guys to have these tools so that you could look at them. If there's anyone who hasn't had that training who would want it, I'm sure we're going to be offering more of those training sessions over time, and then how to integrate this into your practice. So I'm going to move on a little bit. So outcomes of serious illness conversation. It may be that it's just a conversation. They don't want to make a power of attorney, but you know more about what their goals and preferences are. And when that's the case, that conversation needs to be documented in the medical record in a place where it is easily accessed by other providers. It needs to be documented in a way that conveys the patient's current goals and wishes, and can now be billed for using the ACP codes that CMS approved January of 2016. So what I did, I took the bullet points of the serious illness conversation, made it a smart phrase in my EMR. So I can just do .serious, and then it drops this template into my advanced care planning note, and then I can just answer the question. It files to a place in my medical record where it's not buried in a progress note. It's an advanced care planning note, so that if somebody wants to see it from the emergency department, they're 2 clicks out of the header. So looking at how do we make this information really readily available to providers in the emergency department, in the clinic, in the hospital. It is a gargantuan, it took me like 18 months to negotiate, that advanced care planning note type, how to build the infrastructure that we need in the EMR, but it has revolutionized how we talk about these things and how we see what each other's doing. So now I can find the oncologist goals of care conversation in 2 clicks. I open the chart, I click on a button in the top of the header, and I can see the conversation the oncologist had 3 months ago about prognosis. So it may just be that, it may be that, but that unifies us in understanding what conversations have been had, where is the patient at, what do we need to do in continuing the conversation. Sometimes it's going to be that somebody wants to complete an advance directive or a power of attorney for healthcare. And for some patients, they're going to say, I know how I feel about these things, and I want these to be actual orders that move with me across the continuum of care, so that it's with me when I show up to the emergency department, it's with me if I'm in the nursing home and need to be moved from the nursing home to an acute care facility, or it's with me so that EMS providers know what my wishes are when they're moving me from one place to another. And when somebody wants their preferences turned into actual orders, that's where the concept of transportable physician's orders for patient preferences come from. So if we've had a really great conversation, but the person gets out of the hospital and their information doesn't move with them across the continuum, their goals get lost in the transition, they get sick, their goals aren't communicated, they end up back in the hospital in crisis, and we go around and around. This slide is the reason why I decided to start working with the Center for Practical Bioethics in 2008, because I was feeling this. I had this great goals of care conversation with my patient in the hospital. We knew exactly how they felt, but we had no tools for all of that work to move with them. And then they'd go to long-term care, they go home or wherever, and then they'd come back and they'd be like, but we talked about this. But there was no way for the rest of the healthcare system to know what we did. So that was my own personal impetus for wanting to get started in this work. So serious illness care planning will be most effective if the outcomes of those conversations are transferable across the continuum of care. And how is that? That's community infrastructure that gets us all on the same page, built to ensure that the goals and preferences are known, reviewed, and respected in transition as appropriate. So this brings us to what is POLST. POLST is Physician's Orders for Life-Sustaining Treatment. It started in Oregon over 25 years ago. It converts patient preferences for treatment into actionable orders that move with the patient when they go, to be reviewed and respected as appropriate by providers all along the continuum. So training long-term care, hospital, and EMS, and medical, all types of medical providers to recognize the standardized language on the form and know that we're all on the same page about how those orders came to be, what they mean, and what we do with them. So there are presently 43 states, I got 44, working on paradigm development. There are 16 endorsed POLST programs. That means that they've got enough of the infrastructure in place in those areas for that there's a national group that helps to standardize what we're doing, always working on process improvement and learning from each other about that. So there's different names in different places. In Oregon, California, many places it's called POLST. New York is MOLST, Medical Orders for Life-Sustaining Treatment. Virginia is POST, Provider Orders for Scope of Treatment. And we had to be different. I wanted it to, we both did, wanted it to say Transportable Physician Orders for Patient Preferences. And have that be really blunt. This isn't a doctor sitting in his office writing up orders about what people will and won't have access to at the end of life. Really not the point. The point is to improve congruence between what the patient's saying they're hoping for and what the medical system actually does when the time comes. We know there's new language and regulation from Kansas on PAs from within the last year that defines DNR in scope of practice for PAs. We will be updating our language around this so that, especially rural areas where PAs may be working in these workflows, to update it for that. There's also understanding about nurse practitioners working in collaborative practice agreements. So how the collaborative practice agreement is organized determines what falls under that and the nurse practitioner's ability to sign the form. We may at some point start calling it Transportable Physician's Orders for Transportable Provider Orders for Patient Preferences as opposed to physician. That will include the scope of who can sign the forms.
And Lori, are you in collaborative practice?
Yes. This is a national map of the states. The darker pink the state is, the more ingrained it is into their medical culture, a number of people and institutions who have forms. Kansas and Missouri are currently light pink. We're getting ready to change a shade of pink, one of our goals. We're not going to be the darkest, but we'll be one shade darker. So hopefully that will be happening in the coming months. Though there's just a few states who are still white with nothing going on. So this is happening over most of the United States. Really important to point out the difference between an advance directive and TPOPP. Advanced directives are for every adult. They define preferences about a future state of illness. They're a directive, meaning they come from the patient about what the patient wants to see happen. They need to be retrieved. They require interpretation about the future, and they fall under Kansas statutes for patient directives. So when somebody fills out an advance directive, it has to be signed by the person, by a witness, by who else? Notary? Yeah.
Depends, right?
Yeah. So they fall under all of the statutes and Kansas regulation about advance directives. There is a form called a DNR request form that is in statute in Kansas. It is a patient directive saying they want to be a DNR, and the physician signs it saying they acknowledge the patient's preference. Very important to know, that thing is a directive and how that is completed compared to transportable physician's orders for patient preferences. So TPOPP, for folks, a voluntary thing for folks who fall in a serious illness category, defines preferences for treatment in the current state of illness. It is an actual order, an actionable order, to be reviewed and followed as appropriate. Stays with the patient across all care venues and prepares for immediate action in the present. So I don't know if you guys have these horror stories. We have the horror stories of the family standing in the home with their loved one who's coding, and EMS, and they're saying, please don't code my loved one, he doesn't want this. Or even having an advance directive saying, he didn't want this. And the EMS provider saying, I'm sorry, if there's not an order here, I am not allowed to not code this person. And they call their medical control, their EMS supervisor, who will say you can stop or will not say you can stop. Say you have to code this person for 20 minutes. That happened to one of my clinic patients a few weeks ago. They mandated a 20-minute code of my 70-pound, horribly cachectic patient who wasn't, her goals, she wouldn't sign an out-of-hospital DNR, and so that's okay. I think it actually went down the way she would want. You know, her family did not want to be seeing that happen, though, and it put them through a whole different set of circumstances. So having an order in place is necessary for the whole system to be able to operate when it comes to that time. Is this effective? So looking at the Journal of American Geriatric Society 2011, they looked at 90 nursing homes in Oregon, Wisconsin, Virginia. There were 870 patients in this study. The consistency between the treatment preferences and the orders, Section A about code status, 98% consistent. Section B about level of intervention, 91% consistent. Higher than traditional advanced care planning type documents. This one's really important. This is JAGS in 2010. So you can look on there and see Section A of that pink form is about do they want coded or not. Section B is about not coding yet, but getting sick faster. They want comfort measures, limited additional interventions, or full treatment. And so of the folks who put they wanted to be DNR, 300 of them wanted comfort measures only. And the other 326 wanted something other than comfort measures only. So they didn't want to get coded, but they did want other things that medical providers could do. There's good data to suggest that DNR orders get overinterpreted. That when somebody's DNR, all of a sudden we're making a bunch of other decisions that don't relate to whether or not they're going to be coded in their global plan of care. I used to argue a lot when my cancer patient would go to the ICU because they were septic, and the ICU guys would say, well, this person's DNR, why are they coming to the ICU? I'm like, well, are they coding right now? No. Well, why are you talking to me about their code status? Or we should treat these sepsis so that they don't code. So a lot of this is really taking a deeper dive on what does that mean? What does that mean for their goals of care and the medical interventions that they may or may not want, and that may or may not be helpful for them to return to their version of quality of life. So there's a lot of, I was put on a table, a lot of politics around this issue. And around is TPOPP trying to limit access. I know it's really about improving concordance between what people say they want and what we're doing. And that piece of data, I think, is really important. That if we do a better job of this, we'll quit over-interpreting the concept of DNR by itself and start matching things up better. Residents who had a pulse form stating they wanted full treatment received the same level of treatment as somebody who didn't have a pulse. Another really interesting thing, well, the folks who had pulse forms that said they wanted to be DNR with comfort measures, significantly less likely to be hospitalized and receive care in an inpatient setting at the end of life. So when somebody wants comfort measures, they're more likely to get it, which fits with what people say they actually want at the end of life. So this was pulse and EMS. They looked at paramedics about how often had they run into pulse forms and what did they do with the results. So about 66% response rate on that one. 73% had treated a patient who had a pulse form. In 45% of the cases, they said that the pulse form impacted what their treatment plan was going to be. 91% agreed that it was useful in determining treatment when the patient was pulseless or apneic, so made it more clear for them. This one's looking at pulsed and DNR orders in out-of-hospital cardiac arrest situations. 82 of 1,500 people had a pulse form in place in this study. The people who had pulse saying DNR did not get coded in 94% of the cases. Patients with pulsed with full resuscitation were even more likely than those with a DNR or no pulse to have resuscitation attempted. So really tells you about congruence between what's on the form and what the system actually does. So bringing this home, we talked about why we're called TPOPP. Now I kind of wish we weren't so different, but I'm glad. Maybe everybody else will change to us someday. Who knows? So you have in front of you the TPOPP form and what it looks like. Section A is about, it's a code status order. B determines level of intervention, somebody who's getting sicker quickly, but they're not coding yet. Section C is about medically administered nutrition. In both Kansas and Missouri, we have statute that states that somebody needs to make a clear statement of what their wishes are on this issue, and if they make no statement, overt statement, then the default needs to be to do. So, which neither here nor there is a section on the form where somebody can make a statement about how they feel about it, whether they feel strongly that they have it, or they feel strongly that they don't, or that an intermediate trial period is fine with them. So section D is signatures, and important to note that these forms require a patient or their representative signature on it, in addition to the provider's signature. And Oregon, and I think there's a few other places, it's not required to have the patient or surrogate signature. We felt like it was absolutely mandatory that it be known that the patient, their representative, were involved in this conversation. They know what the form says, they agree with it, and so they are signing it that, yeah, I know this, and this does represent what I think. We did something new on the TPOPP form. We were the first paradigm in the country to add goal statements in section B. I thought it was important to get away from the idea of checklists about treatments and really start moving towards what are you hoping to accomplish with the treatment that you're getting. So you'll notice in section B, under each one, there's a goal. Comfort measures goal, attempt to maximize comfort through symptom management only. Limited is attempt to restore function of the treatment for reversible conditions. Full treatment, attempt to prolong life by all medically effective means. So we did a study on this and had we had lay people, we had EMS people, doctors, nurses, nursing home people, look at two versions of the form, one with the goal statements on there and one without. And like 91% of the various groups felt like the treatment goal statements improved the clarity of the form when they read it. So we felt like it was an improvement and really happy about that. We're working to get that data published. But the thing I think is most telling about it is that multiple other states now have treatment goals on their form. We work at the bi-state level, but then we also work nationally, and we're constantly sharing best practice across all of the paradigms in the United States. So that made me happy. It called out, people thought that was good, and they're picking it up. So we've talked about who might have a TPOPP form, living with advanced progressive illness. Not appropriate for somebody who has years of life expectancy left. They need traditional advanced care planning documents. And anyone who doesn't want it. TPOPP has always, this is hallmark, has got to always be a voluntary decision. So we see places across the nation where it gets like written into the requirements of the nursing home admission, and all of a sudden, in order to go in the nursing home, you have to have a TPOPP form. Cannot happen. Absolutely cannot happen. Because if it's required, then all of a sudden somebody shows up to the emergency department, the veracity of that form, does it actually represent what this patient understands and wishes for their treatment, comes into question, and that can't be the case. So how we build the workflows around it in long-term care and hospital settings, et cetera, really important that we pay attention to that. So we started working on this in 2009. The Center for Practical Bioethics and my hospital sit on the state line. And we knew if we wanted anything to be successful in the Kansas City metro area, it had to address both sides of the state line. That's how we ended up in the mode that we're in. So we did a small pilot in Topeka in 2010-11. They're still on the ground there today. And then there are coalitions across the states of Kansas and Missouri who are working in multiple different places. Let me move this one. Oh, you'll see the slides in the next couple hours about where all things are happening. So we work on a standard of care implementation. It's probably important to point out. So some states have laws saying we have to have TPOPP, and so it's legislated. We work on a standard of care approach, which is a bottom-up community standard of practice, best practice approach. This is how POLST originated in Oregon. There's no legislation around to mandate POLST or anything like it. I come at this particular question in a libertarian sort of view. This is about doctors and relationships with their patients and families, and the legislature does not need to be anywhere near the doctor-patient relationship and the decisions that get made. The other thing is that everything about this is about good communication, about good teamwork across the care settings, and really unifying health systems and communities to do a better job of patient care for seriously ill patients. And we don't need a law that says you need to do a better job of taking care of your patients. Anyway, it's important. It's a common question that comes up. Is it legal to do this? Well, yes, it's legal to do this. Everything about this falls under the standard of care. Everything about this is about improving what we're doing. So our leadership scope, we work to coordinate information and data collection. We also work with the regional and the national coalitions for what other places across the country are doing. We help to provide infrastructure for educational training, and really in a train-the-trainer model, and then share best practices and lessons learned. We have a TPOPP website where you can go to access a toolkit. We're always working on trying to improve that toolkit of resources around policy development, education, those sorts of things. We've started videoing these, so this will be a webinar type clip that can be accessible from the website for people to go view and get the information remotely later. So this is just a little bit of a scheme of what does our oversight look like? At the bottom of this is the most important thing of all, and that is the community task forces. So it's very much a bottom-up thing. If a community decides, we want this, we want to build this infrastructure, we want to do a better job at it, then our job is to help provide the tools for that community to come together. But it is very bottom-up. They worked in community coalitions in California. California has legislation and a $1 grant that they had to implement it. Sorry, California. We've always worked on a shoestring budget. I've always been jealous of California. But what they found was that even if you have a $1 and even if you have legislation, in order for this to work well, it has to come at the community level because it's about teamwork and communication tying us together. Who's on these task forces? Hospitals, hospital associations, long-term care associations, hospice and home health, medical societies, physician organizations, the Bar Association, foundations. So this really is cross-cutting and inclusive as we can get it to be. So joining the movement, that's something that a community decides they want to do. What are the steps? First of all, the community has to come together. The core elements of that community have to say, we're all on the same page, and we'd like to see this happen. Next is policy and procedure development for each element of that continuum of care. Third step is system changes and building the tools that are necessary to prepare for this to work right. 4 is education. 5, implementation. 6, monitoring and performance improvement. Some of these they run in parallel. I'll tell you at KU, we went live with a variety of improvements in how we do advanced care planning and our resuscitation status stuff, and it all linked into TPOPP. We went live in December. So my first steps were all of the hardwiring I had to do to our systems at KU to allow TPOPP forms and better advanced care planning tools to exist in our EMR. Negotiating with all of the different health information management systems, the nurses, the social workers, all of their workflows around how do we get this, to work. And right now, it's 6 months later, and we're still in the process of education and figuring out, all right, all of our training has to repeat itself ad nauseum and infinitum for all new residents, fellows, nursing hires. So we keep learning. How do we implement? And it's a constant process. I'm also, now that we're live, now is when I'm starting to build our tools for automated reporting. How many times when somebody has a code status order change, is there an advanced care planning note that accompanies it? How often when somebody has a TPOPP form, how often can I find it in the medical record? Was it scanned? For veracity of our systems in place. So if you want to do this, registering with the Bi-State TPOPP Coalition online is an important first step. And that gives you access to the toolkit, which can help to put some structure around what needs to happen to make it for real, preparing the systems, and then training facilitators. So there's the training of the different folks who run across the forms. What do they do with them? And then there's training providers and serious illness conversations themselves. Two sides of the same coin. Commitment to implementation. The coalitions should meet monthly to be addressing where things are at and keep work going forward. Leadership of local coalitions, conferencing in with each other and with us to answer questions and share best practices. So, and then being prepared for standardized data gathering, that sort of thing. So we keep this, in my wildest dreams anyway, if we actually do a good job of this, what will we have accomplished? Really making a major improvement in matching the care we provide with the care that patients desire, impacting how and where patients and their families go through end of life, and improve the level of coordination across the care continuum for one of the most vulnerable populations while still respecting their voice. I hope this is my whole life, if I get through this, I can retire. So I hope we get there. So thank you very much for your time.